the indications. So we'll talk about the AIUM statement of the indications for doing ultrasound on the hand in general. These aren't specific to dorsal or volar or fingers, but we did go over these in the last webinar. So if you didn't catch all those and us talking about that, go back and catch the part one. For this part two, we're going to stick to the bony landmarks, which change a little bit on the volar hand. We're going to go to the interosseous muscles, flexor tendons, lumbrical muscles, and if there's time, we'll get down to the flexor tendon pulleys of the finger, but that'll very likely also be kicked to the advanced section. We'll cover more detailed finger because we have extensor hood to cover on the advanced. So maybe keep an eye out for that to be added to the advanced section, since we'll already be talking about the extensor hood complex. Uses of ultrasound in the volar hand, very similar to the last one, mostly solid cystic. I think is going to be a big answer for you. High yield would be, ganglion cysts, for example, or tendon tears. If it's a retracted tendon or a ganglion cyst, we see that quite a bit in the hand. Muscle atrophy will be a big one. We're going to go over all these muscles, and if you have muscle wasting in the hand, you might want to go check out the nerves, and the nerves will be covered in the advanced part 4. Bones of the volar hand, very similar, so I just kept the same graphic. We do have the same distal radius and ulna. Carpals, we have a first and second carpal row. Metacarpals didn't change, neither did the rest of the carpals. So we're just going to keep going here. Starting at the wrist crease, they're about a little bit after or distal to the wrist crease. We have 2 bony prominent landmarks. On the ulnar pinky side, we have the hook of the hamate, and on the thumb side, we have the trapezium. And that's going to bridge a gap here. We'll talk about a little bit of the carpal tunnel later, but we are going to reference hook of the hamate quite a bit when it comes to the origins of some of these hypothenars on the pinky side of the hand. And as we scan a little bit distal, you can see the region of interest has changed down here to more of the palm. Getting into the palm, we've got the second on the radial side, third in the middle, and fourth base of the metacarpals. We'll talk a little bit about tendon insertions from the forearm on that, and origins of some of the tendon heads of the hand. Oh, I clicked once too far. Go back one. The mid shafts of the metacarpals look the same as dorsally, just deeper. And so there's more posterior acoustic enhancement. They do look a little bit brighter. They have a more interesting surface on the volar side because some of the muscles originate along the mid shaft of these metacarpals. And we're going to focus mostly on the cross section because it is the best way to survey the hand. In the live demo, we'll switch over to long axes of each of these, but the best reference for the hand is to get really familiar with cross sections. We're going to stick with cross section on these. And then as we go distal, we travel towards the metacarpals, metacarpal phalangeal joints, but without quite getting into the joint space. Just before the joint space is a volar plate that we'll talk about towards the end. And in between these volar plates, there's a big, thick connective tissue layer called the intermetacarpal ligaments, or the transverse metacarpal ligaments. And these are great landmarks to differentiate the superficial layer from the deep layer. For example, there's a muscle belly here we'll go over here shortly called a lumbrical, and it stays shallow to this ligament, and the deeper interosseous structures dive deep. And then the flexor tendons stay on top, and the tendons of the interossei stay towards the dorsal hand, for example. And for that, let's just survey the bones really quick and their contours and some of the tricky areas where they cast shadows. One sec while I go to the live demo. All right, just like last time, we've got the hand here. We've got 2 camera planes to kind of go off of. We've got a top view and a side view. So everything is kind of seen orthogonally. Lay down the gel right at the beginning of the wrist crease. So you see a landmark here. We've got a wrist crease. Just distal to the wrist crease on the pinky side. You can feel the participant. That's easy to image. In fact, we'll probably just start with that, even though it wasn't on the PowerPoint. Landmark. Okay, so left side of the screen is ulnar. So that would represent this side. So left side of the screen is over here. Right side of the screen, the thumb side. You can see these things move a little bit. And then we get an arrow up so we can start talking about all the land. So let me go back to the wrist crease where we see the pistol horn, which is not on the PowerPoint. I apologize, but you can go back to the carpal tunnel PowerPoint and really get an idea of all these layers. But from a bony contour standpoint, if you can find that palpable pisiform, and then over here you don't really palpate scaphoid so much. So the pisiform is your best landmark over here on the pinky side. And then you pull the transducer towards the fingers a little bit, that bone will drop into a valley. And then you'll get another midline bony landmark right there. That's the hook of the hamate. And then I'll plant the hook of the hamate side, and then my windshield wiper, the radial side. So we get another prominent bony landmark right here. And how do we make sure that's not scaphoid? I'll just keep sweeping posteriorly. There's scaphoid. There's a cartilage on top. The tendon that we're going to cover here in a little bit. But the trapezium is this button. It has a groove in it. Right here. So this is the trapezium tubercle. And then here's the carpal floor, with that going into the names of the bones. And then as I go more distal, towards the fingertips, you'll see those two distal bone landmarks give way. And now we're into the metacarpals. So here you can see them spread apart a little bit. They cast these nice shadows. There's a lot of posterior acoustic enhancement on the sides because of these muscles. So in ultrasound, anything that's fluid filled will enhance. Less fluid filled is in the palm here because we have all these tendons up here. And the tendons cast edge artifacts. So they don't get frustrated with seeing your picture kind of looks dirty. Like down here, these bony landmarks are really hard to make look nice, mostly because we're getting edge artifacts from all these tendons. Okay. So when you get edge artifact, it casts kind of dirty echoes down into the palm, around the rest of the bones. But watch when we come over here to the feet on the side, over the thumb side, the bones are a little bit sharp. That's probably one reason why ultrasound for fracture in the hand can be a little bit tricky. So don't hang your hat when catching a fracture in the palm because all these edge artifacts are kind of tricky. And anytime a bone casts, like this cast, like protrudes up like a little prominence like this, it can be hard to stand long at because you don't know if you're slicing one side or the other of that ridge. If you're slicing it a little bit obliquely, that may look like there's a fracture. There's almost a long axis here, right on that bone. And if I catch that ridge obliquely, we're going to fall the kind of obliquely sliced ridge. If you're suspecting a fracture. So I'm not ridge, but it's in third digit maybe right left there. See, this is the beginning of that prominence, that little ridge. And I'm not catching the rest of the ridge on this side. We don't want to do one side or the other of it. But right there, the fracture. Just we'll get in with that prominence. It's related in the palm of the muscle here that's starting. And so that's the tendon forward. Long shaft with the metacarpals here, don't fall, things like that. Right, we will have black. Work that fine. And then we'll go this, and follow the shadows until we get. It's a really good repeating pattern when we have these big ovals. They kind of like snowman, like we have in the body of a snowman here. And then as I go a little bit further distal, you see the metacarpal head's flat now. And then here's a structural cover, probably more in the advanced, what it's called a palmar plate, connective tissue layer that wraps around the whole knuckle. And between those palmar plates is a ligament layer right here. It's a great landmark. So we're not taking a look at that ligament layer to assess it or evaluate it necessarily, but it's a good start to say, okay, what muscles should I expect to see where? Because in the dorsal hand, we have the dorsal interosseous and we have the palmar interosseous. And then we have these more distal or deep circles in the dorsal hand, and those are the lumbricals. And we only use them for a little bit of a landmark, but in this one, it's a primary part of the study. So the lumbricals will start superficial to that ligament. And that's why we want to see that ligament. So proximally, you'll start up here by the bony carpal tunnel distally. So look at the hamate, trapezium tubercle, and then distally, you can kind of stop your exam at that ligament layer between the pulleys. We're over here in a separate part of the exam and go over the thumb. The thumb has some unique musculature and tendon, but keep in mind the bones are always going to cast these nice shadows and be landmarks. Count them. The first web space is really big. Here's that first dorsal interossei right here, which was front and center in the last exam. Right? It was really, really close to the transducer surface. So in this case, you get a little bit deeper. That's the bottom.
Hey there, Daniel. Sorry to interrupt you. Could you move the mic a little bit closer to you?
Yeah, we're starting to drift.
There we go.
Oh, the mic fell, Chris. Thanks. You gotta love a live webinar, right? Sorry about that, folks. Okay, how's that?
That sounds pretty good.
Cool. We'll keep going. As I mentioned, this larger linear is great for the hand for surveys. You may want to get into more detailed looks at the hand with something like a smaller 19 to 5 megahertz footprint where it fits into those web spaces nicely. We also have a 13 to 6 hockey stick, also fits into the tight spaces. And then we'll get into the more advanced stuff with our 46 to 20 megahertz transducer later. But let me go back and find a stopping point here, and we'll start up our next round of slides for the muscles and tendons of the hand. As we talk about muscles in the volar hand, I will say we're going to stick to cross section again. There are some beautiful long axis images that we could obtain here, but cross sectionally is where I want your mind to go. And it's just going to be the best way to tackle the hand. Long axis structures are typically very easy to find. It's the cross sectional ones that you really have to wrap your head around for spatial kind of cognitive commitment to what each layer is doing. So let's tackle the muscles of the hand. Again, kind of like the dorsal webinar, I've got the graphics blinking for layer, and we're first going to start off with the dorsal interossei. Again, think about DAB, D-A-B. The dorsal are responsible for abduction, or spreading the fingers apart. The origin of these are the sides of the metacarpals between each web, and they insert at the first one inserts at the radial base of the second, and the second on the radial base of the third, and on the third, on the ulnar side, you see it switches, and because these are responsible for pulling the fingers together. So on the third dorsal interossei, they switch sides a bit and go to the ulnar base of the third metacarpal, and then on the last one, the fourth one, goes to the ulnar base of the fourth. So you can see those in the graphic here. These are little thin little tendons. They tend to all point towards the middle finger. So just imagine that middle finger is the center point, and that these dorsal interosseous are in each web. So there's not a web that they're not in, and there are 4 of them, and they do between each web make their way to point to the middle finger. So the first web, for example, it can't cross over here, so it's got to stay on this side, and it's going to point towards the middle finger by inserting on this side of the second digit. Same thing on the opposite side. When we come over here to the fourth web, you can see that it originates on 5 and 4 and points itself over to the middle finger again. And then when we get into the second and third webs, they just straddle the gap between the metacarpals and point to the mid shaft of the middle again. Palmar interossei, there's only 3 of those, so 7 interossei total. And just think pad, which is pretty easy to remember. We're talking about kind of the palm, the pad. These are deeper. These aren't the more superficial ones, so they're not on the dorsal side, but they're on the pad of the hand. So they are responsible for that says abduction. It should be adduction. So that's my mistake here. This should say adduction. So this brings the fingers together or adds them to the body. So think about it that way. So you can see these guys, they're subtle, they're small, and sometimes hard to trace, but we've got the first palmar interossei right here, and its origin is the mid shaft of the second metacarpal, and it inserts on the ulnar base of the second proximal phalanx. There are contributions of these fibers that go to the dorsal extensor hood, which we'll cover in the advanced portion. The second skips the middle finger completely and goes all the way over here to the fourth digit, and its origin is the volar mid shaft of the fourth, and it inserts on the radial base of the proximal phalanx. Also contributes fibers to the dorsal hood. And then the third, the last one, you see it originates on the radial base of the fifth, attaches same away from the middle finger. There's kind of a pattern there. These all they try to point themselves away from the middle finger, not towards the middle finger, because they are responsible for bringing the fingers together. So they have to think about that mechanical leverage right here. You've got this little blinking muscle here. It's going to pull the pinky towards the middle finger, whereas the dorsal interossei have a tendency to spread the fingers apart. So that's one great way to remember it. And there's only 3 of those on the bottom. Other muscles that involve the hands. So we do have the flexor carpi radialis, which is a wrist structure that we typically talk about and we went over in a little bit of detail in the carpal tunnel webinar. But blinking down here, you can see its path. It traverses over the carpal the proximal and distal carpal row, and sometimes splits to insert on two of the base of the metacarpals, but primarily the base of the second. And it's responsible for flexion of the wrist, and will also aid in abduction of the hand. So it is an important structure. You can have injuries here. It does dive very steep. So this is following the palm of the hand, not rocking the transducer. So it travels past the trapezium here. We'll go cross section in just a second. But you can see how it dives like a biceps tendon in the elbow. So you have to accommodate for that anisotropy here by rocking, putting distal pressure on the transducer, and it will level that tendon out so you can catch those fibers really nice. Transverse carpal ligament is a landmark that we're going to have for the rest of these muscles also, because many of them, as you can see on the thenar side and the hypothenar, they will originate from parts of the transverse carpal ligament sharing their fibrous origin. So we've got hamate or hook of the hamate over here and trapezium. The trapezium has a little tunnel, this groove here that the flexor carpi radialis travels through. And this other little tendon that's highlighted, which is inside the tunnel, is your flexor pollicis longus. We covered that in the carpal tunnel webinar. So if you wanted to see that and how it differentiates itself from inside the tunnel versus outside the tunnel, go back to that carpal tunnel webinar and check it out. But for the purposes of this this talk, we're gonna follow the FCR as it travels distally. I think it's helpful to take that trapezium tunnel right here, this groove, and we'll go back one slide so you can see it leaves the trapezium and dives. That diving shadow has to be corrected with distal transducer pressure. So we'll go back where we were. All right, flexor pollicis longus. This is probably the most fun tendon to image in the hand. It's a big, easy tendon to visualize. It's highly susceptible to anisotropic artifacts, so this is a good one to practice that on. And short axis, if you don't see this tendon floating in the sea of muscles, it's because you don't have it in the right angle, and we'll do that in the live scan. But you just want to toggle your transducer, make this tendon go in and out of anisotropy versus maximum reflection, and then go long axis and really check it out, and then wiggle the thumb or flex the thumb and watch this tendon move. It's a beautiful tendon because it's easily highlighted by the posterior acoustic enhancement of the surrounding muscle. The overlying muscle is more water dense, so it's going to enhance whatever's under it, and it makes it look really, really nice. It does insert to the palmar aspect at the base of the first distal phalanx. Like I said, this is a great tendon for dynamic maneuvers. It's blinking over here in its pathway. Okay, so now that we've kind of built up the back of the hand, we're going to work our way over to the pinky side, or the fifth digit side. This is the small digit, and digiti minimi, as we covered in the dorsal hand, means small digit. So this is this small finger, and anything that references the thumb will be called pollicis. So pollicis means thumb, or of the thumb. So there's also a pattern here between both on these meaty kind of muscles. When you feel the palm here on the pinky side, I'm going to start with a deeper layer called the openins, which just means opposite or opposing. And it's responsible for touching this pinky and the thumb together, or this pinky, if you can get it to touch these other fingers. It basically is adducting the hand together from the metacarpal level. It originates from the hook of the hamate and the transverse carpal ligament, inserts near the ulnar aspect of the shaft of the fifth metacarpal. So it's blinking here. And next, we're going to work our way superficially, and just remember this pattern. It's open ends, and then the next one is flexor, and then abductor. We're going to get to that, and it repeats on the thumb side too. So it's open ends, flexor, and abductor. So just watch that pattern so it's less intimidating when you see this stacking of all these crazy muscles here, that it's not that hard to remember if you can just remember that they repeat on both sides, and they just change names from small digit to pollicis. That's the only thing that changes about the name. So they repeat their order. The name changes because one's going to the small digit and the other's going to the pollicis, which is the thumb. All right, so the next digit here, we've got the next muscle is blinking, is the flexor digiti minimi. Originates again at the hook of the handmate, transverse carpal ligament, inserts on the ulnar side of the base of the fifth proximal phalanx, way up here. So it passes the MCP joint level. Now we've got the function of the abductor, so the abduction, digiti minimi. So think about this, it spreads the pinky out. it's going to see the leverage you get on this. This tendon actually travels all the way up past the DIP level. It originates on the pisiform this time, so it's a little bit more proximal. So you see the illustration has this tail coming off all the way down to the pisiform, and then it wraps superficially over all of these, and it's kind of usually the first one that you see. We saw it when we laid our hand on the table in the first dorsal webinar. It inserts on the ulnar side of the base of the proximal phalanx. Some contributing fibers go up to the extensor hood. It's pretty easy to follow. Now we're on the thumb side. Remember, we have a pattern it's going to repeat. So we have this deep guy here. It's the opponens, the opposing one. It's the one that lets the thumb come touch the pinky. So pollicis means of the thumb. So don't forget that. It originates at the transverse carpal ligament and the tubercles of the trapezium and the scaphoid. So way down in here. So we don't see those deeper fibers going to the trapezium and the scaphoid, but you see how wide its footprint is when it originates here. Next, we've got the flexor again. So just like the digiti minimi side, we went from open ends to flexor. Same thing on the pollicis side. We went from open ends to flexor. The only difference is there's a superficial and a deep head that are pretty common and easy to see. If you catch that FPL tendon that was really fun to look at and you oblique your probe, you'll elongate the fibers of the muscle, not necessarily the tendon, and you get this really, really pretty straddling muscle that goes up and over, kind of like, it looks like a feather-shaped muscle going on each side of this tendon here. So the superficial head originates on the transverse carpal ligament and the trapezium tubercle. If you want to chase that down, it's kind of hard to do. Deep head originates at the trapezoid and the capitate and the palmar ligaments of the and the distal carpal bones. Sometimes it's absent though. It inserts on the radial side of the base of the proximal phalanx and the radial sided sesamoid. So you're going to be looking at it there. Actually, that's a typo. It's the ulnar side sesamoid. So go look for it at the ulnar sesamoid. And then we have that last one, the more superficial one. It repeats exactly like the pinky side did. It's the abduction or the abductor pollicis brevis, originates from the transverse carpal ligament and the scaphoid and the trapezium tubercle. It inserts on the lateral side of the base of the first proximal phalanx. So we see it up more shallow, more superficial, same as the repeated pinky side. All right, so now that we've built up the walls of the palm of the hand, we're going to go through the middle of the hand now and introduce this really cool transversely oriented muscle that we saw in the dorsal hand as a landmark. So this is the oblique head. If you start from distal and work your way proximal, the oblique head is larger. And this is the adductor pollicis. So adduction, or adding to the body. So taking the thumb and adding it to the rest of the hand. Pollicis meaning thumb. So this is the tendon that does attach to the thumb. So it originates at the palmar surface of the capitate and the base of the second and third metacarpal. Inserts on the ulnar side of the base of the proximal phalanx. As we travel further north, there's a broader muscle, but it is thinner. So these two kind of switch, where the bottom one is less broad, but it's thicker. The top one, or the more distal one, is thinner, but more broad across the third metacarpal shaft origin. So this is the adductor, again, pollicis, but this is the transverse head. It originates on the palmar surface of the shaft of the third metacarpal, inserts on the ulnar side of the base of the first proximal phalanx. It does have that contributing aponeurosis that we'll talk about on the advanced webinar as it wraps around, becomes the dorsal hood complex, and we get the ulnar collateral ligament exam for what you might have heard of is a Stenner's lesion. That's the origin of that aponeurosis that we'll go look at in the advanced webinar, is this giant muscle here. All right, let's move over to the live demo. So as we talked about, we left that wrist crease, and we're going to work our way distally, and then we're going to take a look at the walls, I call it the walls, of the palm. Remember that repeating pattern. So we're going to image that really quick, and then we'll work our way down the middle with the adductor complex there. So add a little bit of gel. We should have done that before we got started. Okay, so leaving that last landmark, you can see this really cool triangle that's formed at the palm, and it puts everything into those groups that I just talked about. So down the middle, we've got these tendons that will end up being the flexor tendons, and they go to the finger. So for this part of the exam, we're going to ignore this whole layer in the middle where you see these stacked balls. That'll be the second part of our live demo, or third. If I go to the thumb side, screen right, you can see how this triangular pattern of the carpal tunnel opens up, and outside the tunnel are these big muscles traveling over to the first metacarpal. And we're going to follow that first metacarpal and those thumb structures right here. Okay. And then the same angle, just opposite side, follows the fifth metacarpal, creating those walls, the pinky side walls of the palm. And then let's go down the middle. Remember, we did the bones earlier, so we're going to go just shallow to the bones. So metacarpals again. Here's that transversely oriented, really big landmark, adductor pollicis. It adds to the body, and you can make it move. And everything in MSK ultrasound, just make sure you're making it move if there's any question of what something might be. And as we go distal, you'll see that fiber disappears, and there's a gap between the adductor layer that we just covered in the PowerPoint and then the structures underneath it down here. So the structures underneath it down here are where your interossei come into play. And we're going to ignore lumbricals because we're going to do those last. And we're just following everything that's bordering the skin. So here's the table. So we're going to be scanning all the way through that. Here's that first dorsal interosseous. First dorsal interosseous. And because the dorsal interosseous occupy each web, we know that over here we have the second dorsal interosseous. Let's go over here to the third dorsal interosseous, and then the fourth dorsal interosseous. Now, inter meaning between osseous bones. So between bones, that means if I go further lateral, there's no interosseous over here. That's out there to the table and those meaty walls of the palm that we kind of talked about earlier. So we've left the boundaries of where I expect to find anything interosseous related. And then remember in the PowerPoint, we talked about how there are 3 palmar interosseous muscles, and they skip the middle finger altogether. So we're not worried about palmar interosseous muscles starting on the middle finger, at least in normal anatomy. But on the first, I do expect to see a palmar interossei, or a palmar interosseous right here. So this is the first palmar on the second digit. Okay, and we could follow that muscle belly out, and then I promise some long axis picture. So let's take this here where I expect to see a long axis muscle here and a short axis muscle on top of it. So I'm just going to spin the probe, keeping that metacarpal in place. We have a short axis AD, adductor. So that's moving right there. And then underneath it is a long axis palmar interosseous because it's closer to the transducer. So right where my arrow is, that's a palmar interosseous. So palmar and dorsal. Palmar, dorsal, and then here's that adductor, that big landmark that's in the middle of the palm right there. We'll go short axis again, follow it over to the next web space here. This is the one that involves the middle finger right here. So third digit, I don't expect to see palmar interosseous on either side of it. And I could come over here to 4. And on 4, I expect to see a palmar interosseous right here on the ulnar side. And they're very hard to trace past that ligament. That's why I say the ligament's kind of a good place to stop. You can try to trace past that ligament and get really, really frustrated. You can follow the little heads, these little bright spots right here. These are tendon heads. They're about the only thing that continue to show between the metacarpal heads. The muscles, not very impressive. So don't be frustrated if you can't trace these muscles past that level. They mostly turn tendinous and turn into sagittal band anatomy for the advanced webinar. And then over here in the last web space, we have a palmar interosseous on the 5th, and we could trace it down also. So that's your row of interossei. And remember, there's a little space right here, actually middle finger, where I expect to go proximal, and then we see this big transverse, or I say transverse, it's a longitudinal muscle transversely crossing the whole palm. And to me, that's the home base of a hand exam, is the adductor. And it's a home base of a hand exam because it's in the middle of the hand. It goes against all the other fibers that we're evaluating. So it's a good landmark to say, okay, I'm distal to that landmark, I'm proximal to this landmark, and it's the most, I think, movable landmark to get yourself oriented. All you have to do is just move the thumb a little bit, and it will tell you where you are in the palm. So the bigger that moving thumb muscle, the adductor, ADD for add, the bigger that muscle belly, you're on the oblique head. And as you go distal, 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 see how I'm holding the transducer pretty stationary on the radial side, and I'm windshield wipering the palmar side. And then you get a thin band. That's your transverse. So transverse is thin, but more broad. Oblique is thicker, but shorter on the footprint. And you can track that footprint down to the middle metacarpal, the third right here. And the oblique head has origins all the way back to the capitate. Nobody really looks back that far. It was just fun to find for the purpose of this presentation. But what you're looking for is muscle wasting and atrophy due to nerve compression of radial and ulnar nerve branches here, which we'll get into the advanced webinar. We'll go over those. So after we've traversed those big, easy to scan structures, also get long axis and short axis. So here's your long axis adductor pollicis. We'll go short axis adductor pollicis. And then we can follow that short axis structure right on top of the metacarpals. So that's metacarpal 2. And then 3, you see it dive down to next to nothing. We're going to add some gel to the palm. Right there. So here we're just following that transverse structure as it dives down, 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 down to the 3rd. And then you'll see those contributions that originate all the way back here to the capitate. All right. So now let's go to thumb and pinky. So remember, there's a repeating pattern here on the thumb side. The deep one on both, okay, is think about that test that you would do for a palmaris longus. We covered that in the carpal tunnel PowerPoint. When those two come together, you're going to activate the open ends. And the open ends, let's just wiggle the thumb towards actually the whole metacarpal, maybe even roll the metacarpal. But the open ends will be this deepest layer right here. So we have open ends and then this little bitty fascial plane right there. And that would be where the flexor portion of the pollicis starts. So open ends pollicis, flexor pollicis, abductor, abductor pollicis. Remember, abduction is away from the body. So when she spreads her thumb out, it'll activate that most outer muscle. Adduction, adding to the body, is that big transverse landmark that we were working with earlier. So you have adding to the body, adductor pollicis, and then you have abductor pulling away from the body, so spread towards my hand. Yep, you're activating that most lateral part of the thumb there. So that pattern just repeats. It's easiest to do in cross-section where you have open ends, flexor, and abductor. You can check them out in long axis. I just think it's a little less useful than the short axis because you get volume in the short axis. And they're so close together depending on the health of your patient's muscle content. If it's super healthy muscle, it'll look just like this, where you have this hypoechoic muscle all the way to the border of the fascia between the next one. If it's less healthy muscle, you might get a more fatty rim around the muscle, making it easier to see and delineate that line. But in our patient here today, I don't see any delineation between fascia here. So what you would have to do is move something and get it to cause the fascial plane to move. All right. And so on the flexor side, remember we called out flexor pollicis longus earlier, right here. And on each side of flexor pollicis longus, you have a flexor pollicis brevis. So you have a brevis muscle 1 and a brevis muscle 2. So you have a superficial brevis head and a deep brevis head. And I'm stopping my arrow here because if I go deep to this little fascial line right here, we get into adductor. And if I wanted to find out if that was adductor or not, just knowing where the adductor inserts right up here on the inside of the thumb, what I can do is just twist the MCP joint. So I'm going to grab her thumb and I'm just going to twist it. And you'll see the underlying muscle differentiate itself, especially in that slightly oblique long axis right here. So we'll go to this plane where we had that, the abductor pollicis right here, the deep head and superficial head in the PowerPoint, right next to adductor right here. And all I'm going to do is just make it move by moving and twitching the fiber by twisting the MCP joint, or even bend the DIP a little and cause a little bit more leverage. But that's how you get that fascial layer to show itself. You just want to kind of twist and rotate the thumb a little bit, and you'll get the layers
to show themselves that way. So you can see that this whole layer down here is rocking back and forth when I take the thumb and twist it back and forth. Harder to do with the whole thumb, I've found. Just grab the IP joint down there and just twist. Okay, so that's the difference between your superficial and your deep head of your flexor pollicis brevis, with the flexor pollicis longest tendon in the middle. Like I said, this is the easiest one in the thumb, I think the most fun. And if you are teaching MSK ultrasound to beginners, or you're a beginner yourself, practice that artifact, the angle artifact right here on FPL, because it's such an easy tendon. And watch how very slight of an angle it takes to make a tendon disappear and look like it's completely gone. So practice your anisotropic artifact here. And then I'm going to rotate the transducer and go long axis on the tendon. There. And you can see the tendon takes that turn, the FPL, into the carpal tunnel. Right here. That's why it falls off. I would have to turn the corner and rotate the transducer in. And the nice thing about ultrasound is you can make it move. So I'm just going to twitch the tip of the thumb, and I can follow this exact tendon into the carpal tunnel as I twitch the thumb and follow, twitch the thumb and follow, twitch the thumb and follow. And that's how you can know that you're on the FPL and not the FCR, the flexor carpi radialis that we covered. So if I go more radial from here, we'll catch FCR diving, which is here. See, I'm wiggling the thumb and FPL is wiggling on the side. And you remember that deep, steep diving tendon here? So that's the base of the second metacarpal. So this is flexor carpi radialis. And if I give a heel toe maneuver here, you'll get that tendon to brighten up really nice, and you'll see its insertion here. And if I keep my transducer planted on the left, pivot on the right to the third, you'll catch the other head. So there's two tendon heads inserting. So we've got base of third. That was the second. So this is still second. Here's third. I see some fibers going to third, but not much. That's probably just a ligament. And then to check your work, you could always go short axis. So here we are, short axis, trapezium tubercle here. Here's that groove that we talked about in the PowerPoint. And there's that FCR tendon right here. So FPL is the neighbor. Wiggle the thumb. So that's inside the tunnel. And FCR is outside the tunnel, and it's got its own groove right here on the trapezium tubercle. And we'll follow that shadow as it dives distal, distal, distal to the base of the second metacarpal here. And then there is usually a fiber, or, you know, the anatomy books and everything says there's a fiber that's going to go over here to 3. I'm not too impressed with what I'm seeing here. So maybe not so much on our model, but we can definitely trace it, that shadow right there, to the base of the second. I don't know. There's probably a fiber there. Easier to see the second. All right, so I talked about it repeating a pattern. Let's check it out again just to review. So base of the first metacarpal here, we've got open ends, flexor, and abductor. And then we're going to come all the way over here to the pinky side, go through that triangle of the carpal tunnel, and find our base of our 5th metacarpal here. And it repeats, same thing. So we have open ends, flexor, and abductor. And then the name changes to digiti minimi. So if you're looking at all these on an anatomy diagram, it looks really intimidating with all the labels going everywhere, but it is just a pattern. So we have open ends for opposing. We have the flexor digiti minimi and the AB abductor digiti minimi, and that will be responsible for taking the pinky, spreading the fingers out. That's what pulls the pinky away from the palm. Remember, we had the interossei to pull the pinky in. Now we have this abductor digiti minimi on the outside to pull the pinky out. So that's that pattern there, 1, 2, 3. You could go long axis here too, just like anything, 2 planes. So long axis of your open ends, which has a long tendon attachment all the way across the shaft of the 5th. So we're following all of this is the tendon of open ends right here, right there. See those little, look like waves on top of the bone right there? There's a long tendon attachment across this whole surface, and that's open ends. And then above it is flexor, flexor digiti minimi. And then if we keep rolling on the far, far outside, we'll see a shift in the muscle belly there, and that's your abductor digiti minimi on the outside. So that takes care of the side walls. And then let's go down the middle really quick. Actually, we're going to get into flexors next. So as we transition, we're going to follow this out and we're going to go over these superficial and deep flexor heads.
Okay, just more mid section of the hand and superficial. Let's look at these kind of confusing flexor tendons. We've already covered these muscles deep. So we have our metacarpals mid shaft. So your probe is right here, not quite to the intermetacarpal ligament there, but we're going to look at the flexor tendons. So these start in the forearm, which we've covered in the elbow and we've covered in the carpal tunnel exam. They start way up in the forearm, all the way up to the medial epicondyle, and then they finally come down and they insert at the distal base of the distal phalanx right here. And I'm not going to read this whole thing out. It's more of just a reference for you. But just notice that each of the profundus, which means deep, the profundus layers have a muscle belly coming off of them that starts roughly around the carpal tunnel level. Like if I'm squeezing my hand, I see these muscles when I squeeze travel into the tunnel, for example. It could be confused for fluid. So you don't want to call supposed fluid in the carpal tunnel. It's not always fluid. Sometimes it's lumbricals, depending on the hand, pulling and retracting back into the carpal tunnel. If they become hypertrophic, I suppose they would contribute to the compression of the median nerve. But just take a look at their path. You'll see that they kick off on the radial side of each of the flexors. And the first two don't have a kind of a double-headed origin, but the last two share the walls of each of the tendons here. So you can see the fifth and fourth have an originating layer on the fifth and fourth bellies of those tendons. The third has an originating start at the walls of the tendon here. And then you could say something similar about the second lumbrical here, but it only starts on the radial side of the third. And then same with the first lumbrical to the second digit, only starts on the radial side of that one tendon. So don't go chasing and looking for the origins to all be the same. They're similar, but not the same. And they do travel the most superficially here when it comes to the rest of the muscle groups in the hand that we've looked at. They're the most superficial round balls that we look at in the palm as we get closer to the knuckles. Superficialis layer. So there's two tendon heads if you're scanning the palm. So if you should already be familiar with the metacarpals, the interossei, and the adductor. So those are your common landmarks that we've already been through. Now we're just focusing on this whole shallow row of what just kind of looks like beads. And those are the different layers of profundus flexor tendon, which has the muscle bellies on each side of the lumbricals. And then we have superficialis. So the superficialis are very easy to scan, but it's neat once you know that there's two layers that can be seen in the palm. It's kind of like one of those things that doesn't leave you. You always see it. It's just such a pattern recognition thing from there. Now, the interesting thing about, and I hope we get to this in the live scan, maybe during Q&A, the interesting thing about this one is the superficialis layer inserts near the base of the middle phalanx. So we've got middle phalanx here where it splits. So you see a split more on this oblique view on the fifth, where the superficialis layer has a divide right after the MCP joint. And then you'll see the two heads of the superficialis go on each side of the profundus and then under the profundus. So they switch spots right around the PIP level. So at the PIP level, you should see superficialis underneath profundus and attaching at the middle phalanx walls on the sides. So a little bit of a challenge during the live scan. I'll flesh that out a little bit more. And then in the advanced webinar, we'll cover the pulley system that holds all that together and also makes a really nice landmark for where you should see what when it comes to these flexor tendons. And then each of these has its own tendon sheath. So the fifth has its own solo sheath that kind of contributes down to the main bursal complex of the carpal tunnel, and the FCR has its own blinking over here, or FPL. Sorry, this is the flexor pollicis longus. And then these three have their own that don't communicate and don't contribute. There are anatomical variants here. Some surgical hand atlases show you the various communications and the percentages, which is a good way to chase down infection, as something down here might cause pain and infection up here because there might be a bursal communication to a tendon sheath. Okay, so this will be the live demo, and then we'll go to Q&A after that. So have your questions ready for Chris, and we'll address those during the live demo. All right,
So here we are back on the palm. We're going to focus on that very, very superficial row, and we're definitely going to switch out to a higher frequency transducer after we get through the survey. So again, screen left, radial, screen right. Oh, I got that backwards. Screen left, pinky side, digit mini side, screen right, thumb side, radial side, first digit side. Superficially, we've got, go more shallow. There we go. Okay, back all the way to the palm. So we can see the first set of flexors that we care about, and that's going to the second digit. So we have superficialis and profundus. Let's follow profundus. All right, so I have seen carpal tunnel exams, or people call this bursitis or synovitis right here. So I'm just going to have our model just slowly wiggle the fingers a little bit. And how about a slow squeeze? Now, if those lumbricals are really originating close to the carpal tunnel, when she does a squeeze, the lumbricals will come into the tunnel and it looks like fluid, but it's not fluid because you can't compress it. There's no posterior acoustic enhancement. Other ultrasound skills should provide you clues that this isn't fluid. So go ahead and make a fist slowly. Yep. See the lumbricals travel towards the carpal tunnel. Now I'm in the tunnel itself. See that right there? That's a lumbrical. Lumbrical, lumbrical. And then I could go long axis on that lumbrical. So that would be a pitfall. If you're not familiar that these profundus tendons have a lumbrical traveling with them, you'll see a lumbrical go all the way into the carpal tunnel, in her case, well into the tunnel. And you might call that a bursitis or synovitis, and you might even inject a lumbrical. So follow the profundus layer and see its adjacent. Let's go ahead and extend the fingers. You'll see that the lumbrical kick off of the profundus layer. This is a unique one, the second one, in that the lumbrical travels more superficial than the rest. Just an observation I made where this muscle covers superficialis as well. So it looks like it's coming off both of them. And it might very well be that that's an anatomic variant. I'll say of all of the structures in the body, I feel like the biggest landmines for anatomy variance is in the hand. But this is lumbrical. Now let's go over here to the second lumbrical, which is coming off of the radial side of the profundus for the third flexor tendon. And you can follow that back. And then the pattern, remember, these lumbricals share a wall. These lumbricals share a wall. And what I mean by that is this lumbrical is originating one head of it on the ulnar side of the third and the radial side of the fourth. And they will eventually separate that lumbrical from both of those, and it will head over to the radial side of three. Then we go back up to 4 and 5 flexors to find the fourth lumbrical. Same thing. You can actually see those two muscle bellies split right there, or at least they originate slightly right here. Share, 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 and then one kicks off the other. And now the lumbrical is going to follow to the radial side of the fourth. There. You can see that lumbrical dive. After that intermetacarpal ligament that we talked about right here, or transverse metacarpal ligament, watch the lumbrical take a steep dive, boom, and it will become the extensor hood complex too. It's going to go up and contribute fibers to the extensor tendons. Superficially, we see the superficial ones. It's not as exciting to scan as the ones with lumbricals. I just feel like there's more not pathology, just more anatomy to see with these lumbricals. Now, floating on tops of the lumbricals, not covered here today necessarily, but in the advanced, we'll trace out the nerves. So if you had been through the carpal tunnel webinar with us, here's median nerve just as a bonus, and you'll see it split out to the interdigital branches. So between each of these superficial flexors, and use anisotropy to your advantage. See me tilt and rock. So what's flexor and what's nerve? What's flexor and what's muscle? So the more compact the fibers, anisotropy is more prevalent. So if I tilt slightly, the lumbricals will stay lit up, but the tendons dropped on their echoes, and the nerves will be the last to drop their echoes because nerves are mostly consisting of fatty epineurium and you know, fat's going to stay pretty echogenic because it's not so linear and striated. So these are interdigital nerves, and we'll cover those in more detail and where they go and where they split in the advanced webinar. But we could follow the superficialis layer as it gets really, really close. I'm just going to stick with digit 3. Pick a digit, right? So here we are in digit 3, and now we're at the metacarpal head level because I see cartilage. And if I go distal to that, you'll see the joint space drop, and now we're at the proximal phalanx where there's no cartilage. And I talked about the split of superficialis in the PowerPoint, so let's get to that really quick. And I'm going to switch to a higher frequency transducer for that. Let's get some gel in the track. And this would be a good time to start getting questions loaded, Chris. I think we're good on time for the first time ever. We have 5 minutes left. And I'm just going to do a quick demonstration on how this superficialis splits over the profundus. So metacarpal head level, we have profundus here. Superficialis will split into 2 heads right here as we go more distal, right there. And what's neat, depending on the anatomy book you're looking at, but if you're just ultrasounding, you can see that profundus has a little septum to it too. And it'll be that way all the way to its enthesis. So you can trace profundus all the way to its insertion, and you'll see 2 tendon heads. But if you're looking at anatomy books, most of them don't show a tendinous septum in there unless you ultrasound it yourself, and then you'll see it. I'm just going to switch to the 46 while we have time and taking questions, and I can answer those questions while I switch. And we'll do the Q&A, and then we'll let everybody get on with their day. Okay.
Yeah, just to remind everybody, you can send those questions in. If you're on the Zoom stream, it's the Q&A box on the bottom or the side of your screen. And if you're on one of the other ones, you can just put your question in the chat box, and I'll make sure that gets to Daniel.
Okay, so I'm back up in the palm following number 3. And look how cool all those little bitty nerves that I described earlier look. Now we have interdigital nerves that look as big as the median nerve did on the other probe. So this is the common palmar digital nerves. So watch them split into 3 groups. 1, 2, 3. Right there, they just fell right off the 3rd flexor. And you can already see the big gap between superficialis and profundus here. Shoot a little bit deeper. So profundus, superficialis, and you can see the lumbrical coming off of that profundus. There you see the lumbrical separate from profundus, kind of becomes its own thing as we go interdigital. And the lumbrical will ride on top of that intermetacarpal ligament. As they dive, because this probe has such a thin ultrasound beam, it is highly susceptible to anisotropic artifact. All right, let's watch the split. So just for our own edification here, I'm on the 2nd. No, I deviated. I was on the 3rd. Let's go back to 3rd. Everything stays nice and uniform on the 3rd. What's weird about the 2nd, when you're scanning the 2nd, you'll see that it turns into kind of this yin-yang shape, and it will almost look like it's twisting because the direction of those fibers are headed back to the midline of the wrist. But if you go to number 3, they're more stacked right on top of each other. So we see profundus here, superficialis head. And as we go a little bit more distal, you'll see them split. So there's the split. And for today's lesson, I would just say, you know, if you're not already scanning these distally, be aware of that swap that happens. So now I'm at the PIP level, and now we have profundus on top. These are superficialis tendons on each side. And the superficialis will keep going, keep going, keep going. Right there. That's the anisotropic insertion to these little tubercles that sit on the base of the proximal phalanx, middle phalanx, sorry. But you can see this dark layer right here. Watch when I go long axis, you'll see a long axis tendon attaching to that little tubercle. So I've seen that called a fracture, that tubercle, and I've seen these tendons, the anisotropy called tenosynovitis quite a bit. But that's a long axis insertion to these little side tubercles on the middle phalanx of the superficialis right there. So I'm extremely radial on this finger. So there's the PIP joint and volar plate complex, which we'll get into on the advanced. But we can see her cartilage and her volar plate. We can go distal, distal, distal. But there you see a divide right here. See that little septum right here, where one is going to continue on and the other is deeper. they switch places when I go proximal. When I go proximal, that divide is in the middle of the tendon here, and that becomes superficialis right there. So what it is, it looks like this, and you're just taking a slice through that twist, and it casts that crazy shadow that makes it a little. You either think it's hard to scan, or you think something's wrong with the patient's tendon. You might call like a longitudinal split tear or something of a flexor tendon, and really we're just looking at that divide where the two tendons are, one's overtaking the other. Easier to see in short axis. So here's that septum between superficialis heads. There we go. And then there you can see it wrap around. So if you want to see how to scan that and the troubleshooting it takes to really evaluate those flexor tendon slips into their insertions in the pulley system, catch the 4th webinar, the final one in the hand series. The next one, I think Chris will have the date offhand. I think it's September 29th is our arthritic hand webinar, but we can take questions now if anybody had any.
Yeah, as Daniel said, our next webinar is on September 29th, and that is on the arthritic hand. And we also will have a guest on that one, Dr. Daniel Malone. So yeah, you can go to our webinars page to go ahead and sign up for that one. Doesn't look like we have any questions coming in. Not sure if there's anything else that you want to show off at all, but we can take a look at that.
Oh, there's so much with the ultra high frequency. You can just geek out so much. It's crazy.
Oh, sorry. Just had one come in. Can you show us how to scan UCL for the thumb?
That'll be on the advanced webinar. But to tease it out a little bit, I will say, we have that transverse muscle, the adductor, because we're adding to the body, right? So we got that big transverse muscular landmark right here. And on her hand, we can actually see it still. We're told that at these super high frequencies, you'll never penetrate deep to a centimeter or so. And in some cases that's true. It just depends on the skin. But we're removing the adductor, and where its fascia, where its tendon becomes fascia, right there on the under surface, right there. We'll pick up where I'm leaving off in the advanced webinar. We'll be able to trace these fibers up and over, and then we'll flip the hand over and really catch the complex right here on the bottom of this, the top side of the knuckle. But we're definitely going to cover not only the UCL of the thumb, we're going to cover the collateral ligaments of the MCP joints, what you can see, what you can't see, so you're not just spinning your wheels trying to see things that ultrasound's really not great at. And then you'll see the parts where ultrasound is really strong. So yeah, don't miss that. I think the advanced webinar is the first week of October. Isn't that right, Chris? Like October?
I believe 7th. It's October 7th.
7th, yeah. Mm-hmm. Definitely excited because ligaments are kind of a final frontier of diagnostic exam for a lot of people. So there's a lot of nuances to the bony landmarks, like here on the thumb, without totally giving it away. We've got sesamoids to deal with, right? And everybody has sesamoids of the thumb, but not everybody has sesamoids of the fingers, but some people do. So there's a whole slew of anatomic variants we're going to cover in the advanced, things to watch out for, little landmines. And then we're going to cover other structures like the ligaments and nerves and some of the vascular structures that'll help you navigate a hand exam. Then we're also going to go back to the dorsal hand for the advanced hand webinar, and we're going to go over the sagittal bands, the collateral ligaments, the whole extensor hood mechanism. Remember, I talked about those contributing fibers that come off the lumbricals. We're gonna scan some of those down to their terminations. So very excited for that. But if that's all the questions, it sounds like I've talked enough for everybody. They're just ready to go. I understand.
Yeah, it looks like we don't have any more questions. Let's see. Oh, we have one. Can you scan the TFCC?
So in the wrist webinar, we did a dorsal wrist webinar where we covered that. This transducer is not super famous for penetrating those anisotropic ligaments really well, so I'd probably want to change over. But go catch the dorsal wrist webinar where we did cover the TFCC in more detail. But if it's your first exposure at ultrasound, I don't mind just giving you a glance while we're waiting on another question. But yeah, that would be more of the wrist exam, and we've done wrist webinars already. So there's screen left, we've got the ulna. screen right. Down low, we've got lunate. And then triquetrum is the far guy. And then we have an old TFCC injury here where you can see there is an avulsed segment popping off that triquetrum right here. So kind of fun to see a little bit of pathology there. This was a problem a long time ago with her. She had extreme pain that radiated down the outside of her wrist into her palm. And this was rubbed right up against some of those nerdy ulnar nerves, right? So there's a superficial and deep ulnar nerve we'll cover in the advanced. But just for fun, while we're waiting here, here's pisiform, here's ulnar nerve and Guillen's canal. And then as we go past Guillen's canal, you'll see the hook of the hamate, that one bony landmark we covered. So follow the nerve and you'll see it split before the hamate. And one will follow deep to the neck of the hamate right here, deep motor. And we'll cover that in the advanced. And we're going to go down the whole palmar arches. And then here, superficially, you can see the superficial branch right there. But right up in that split in that area, just proximal to this is where she had a cyst and some fluid. And then eventually we found that fragment of bone, which was not cool. But yeah, TFCC, here's your major cortical landmarks, ulna, lunate, triquetrum. Far distal in the image down here, as far as you can shoot deep, you'll catch the shadow of the radius. Turn the gain up way down there. Yep, this is radius. And then here's the cartilage complex, more like the ligaments as they crosshatch across each other. It's a triangular fibrocartilage complex would be right here. So meniscal homolog being this triangle space here. So we got meniscal homolog on one side. The names of the ligaments on the ulna are slipping my mind because I'm fried from the hand prep. But what you're looking for is what we see right here. You can see that avulsed segment coming off triquetrum. It's not bothering her today, so that's good. But it looks cool for the webinar. Thank you. All right, looks like we've hit the hour. And I thank you, everybody, for joining, and can't wait to have you catch us with our guest speaker, Dr. Dan Malone, September 29th.
Yeah, absolutely. As you can see here, you can go ahead and scan that QR code to visit our webinars page. And I know part 3 is up on the webinars page. I think part 4 will be up pretty soon here. So yeah, we look forward to seeing you with those. Daniel, thanks again for the amazing insight into the hand. And yeah, we'll catch you all next time.